Okay, so hey, good morning, good evening. As the words of the our friend Dr. Kianor, good morning, good evening, good afternoon, good night to everyone who is viewing this live webinar today. So it's very I'm excited for the topic today because it's a it's I'm by the way, I'm Dr. Carlos Santos. I'm from the Philippines. I'm a practicing dentist. I'm excited because the topic for tonight is not about my profession. It's a whole lot. It's way. I mean, I'm really interested. It's about optometry. Okay, so we're really getting the hang of our doctor to doctor uh, engagements here in the in Global Summit, Doctor to Doctor Uniting. So, well, our guest for tonight, our guest lecturer for tonight, Dr. Jameel Rizwana Hussaindeen. Okay, so I'll do the introductions in a bit, but I just want to ask Dr. Jameel, how are you, Doc? How are you? How's everything? I hope everything's fine. How's the situation there? I'm happy that you have time to be part of our doctor to doctor program. So how are you, Doc?
Thank you, Dr. Carlo, first of all, for being the host for this webinar. So it gives me immense happiness to be present on this very unique venture. So I was just telling Dr. Kianar that this is, I would say, the first of its kind where doctors are coming together and discussing on multidisciplinary approach. So first of all, I'm super excited for the next hour ahead. Coming over to the situation in India, of course, it is getting better. It is the second wave has been worse, but it is getting better, and our community is quite safe in here, and families are safe. So, so it is, it's quite relieving that that things are getting better. We are under intense lockdown, but that has also given me the opportunity to be able to allocate time for this webinar and be able to do this virtually. So I'm excited.
That's good to
Overall.
hear, Doc. So you're a practicing optometrist, if I'm not mistaken, Doc, right? So,
Yes.
is this what you really wanted to become when as a child? Because I personally, I wanted to become a lawyer, but but I'm happy now in my profession. But how about you? Is this really your dream? Being a an optometrist, or how did it happen? Is it by chance or
It is
yeah?
basically a very serendipitous chance, I should say. I wanted to really become a doctor from childhood.
Mhm.
I was like, as you wanted to become a lawyer, I was between becoming a doctor and getting into some administrative stuff in the politics, basically,
Oh,
um,
whoa.
because speaking is my passion.
Okay.
But somewhere, like, my heart was more towards serving people and getting into healthcare. So right after my high school in here, I got an opportunity into the #1 optometry school in the country, the elite school of optometry at that time. So I didn't know about the legacy of the school, but that's why I said it is such a serendipitous thing in my life, and there's been
Mhm.
no looking back since I entered that school, because my career and my whole optometry journey has progressed in ways beyond my own imagination in the school and in the institution, the Shankar Netralaya, that's like the school and the institution are like together. We get trained in the hospital, and so these two institutions have helped me to grow to where I am today. And so, so I love teaching, I love practicing, and that's how I got into optometry.
So, doctor, correct me if I'm wrong. So, an optometrist, so an ophthalmologist, does an ophthalmologist know how to do optometry work, or vice versa? Is it? I mean, I really get confused when it comes to that. Could you
Right,
explain that? Yeah. So there.
right. Yeah, so optometry is basically a primary eye care, it's basically a primary healthcare profession.
Mhm.
where, right after your high school, this is how it works in India, but of course it works differently
Yes,
outside the
yes.
country. For example, in Philippines, you have a doctor of optometry program
Yes,
where
yes.
they directly become the doctors. And same way in the United States, you do an undergraduation before you get into the optometry school. But
Yes.
in India, right after high school, you get into optometry. So optometry in India is still I would say, a baby profession.
Okay.
Fortunately, this year has seen the recognition and regularization of the profession by the government. The government has, released an act saying that optometry is an independent healthcare profession.
Mhm.
So when it comes to ophthalmology, of course, like how you have the MDs, it's
Yes,
basically
yes.
right after medical school, you
Mhm.
pursue a specialization in eye care and then you become ophthalmic surgeons. So that's
Mhm.
how optometrists and ophthalmologists differ in terms of the providing service. And
Okay,
coming to
okay.
whether ophthalmology knows optometry, yes, because optometry is all about primary eye care, and that definitely goes into the ophthalmology curriculum as well. But optometry, when it comes to the vision science perspective of
Yes,
optometry,
yes.
optometrists tend to learn a lot in depth about the visual science, the mechanisms. And so many of us actually
Okay.
even explore a lot of vision science research, understanding how the visual system works and functions. And so optometrists
Okay.
are more specialized as vision scientists. Yeah,
So ophthalmology is more of the like the pathology or the disease, right? Am I
exactly.
correct?
Yes, the
Or
disease
okay.
management and yeah, the disease management, the surgical management. Yes.
Yes. Okay. So well, I'm gonna read your sorry. I'm gonna read your bio now, so the audience may have have information about you. So okay. So let me just read this, ladies and gentlemen. Okay. So okay. Well, before I read this, I want everyone to if you want to what do you call this? If you want to get a clearer idea, okay, of what this doctor to doctor program that we are having right now, please log into Facebook and yeah, just enter our Facebook page, Global Summits. Okay, so there you'll be informed about everything. So there are QR codes located here in our left and right. You can also scan that to have an idea of what this wonderful program that we are starting to here. So the effect that it will bring to the world in terms of doctor to doctor patient relationship. So okay, with that, I want to read Dr. Jamil's bio. So Dr. Jameel Rizwana Hussaindeen is currently serving as an honorary visiting consultant and faculty, okay, at Sankara wait, let me pronounce this. I don't want to butcher this. Nidralaya, Chennai, where she was the former head of the Binocular Vision and Vision Therapy Clinic, okay, at Sankara, okay, India, where Dr. Hussein Dean, is the first clinical diplomate from India in the section of binocular vision, perception, and pediatric optometry of the American Academy of Optometry. Wow. And is the inaugural president for the AAO India chapter. Okay. Dr. Hussein Dean's expertise spans across clinical specialties of binocular vision, pediatric optometry, learning related vision problems, cerebral visual impairment, amblyopia, and neurooptometry. She serves as a committee member and trainer for the Rashtriya Bal Swatiya, sorry, Swatiya Karyam Kram RBSK, Government of India's initiative in the preparation of a manual for the vision assessment and rehabilitation of cerebral visual impairment, CVI. Dr. Hussein has been involved in the school eye health initiatives for over a decade now. Her doctoral research pertains to understanding binocular vision anomalies among school children. Dr. Hussein has many peer-reviewed publications in the international journals and also has authored chapters in books. She serves as a reviewer for national and international peer-reviewed journals including Optometry and Vision Science, PLOS1 plus 1 BMJ-BGO, Journal of Optometry, Indian Journal of Ophthalmology, and Nature Scientific Reports. Dr. Hussaindeen is currently serving as the president of the Optometric Association of Tamil Nanbargal, OATN, the Legal Association of Optometry in Tamil Nadu. So, man, this credential is I think more than any can top off any any ophthalmologist in her field. So it's it's a very wow, your credentials are very. I mean, if I had this, I'd be really really proud, you know. So without further ado, I'd like to give the floor to Dr. Hussaindeen. So she will be lecturing to us a very interesting topic, about pediatric vision or eye care. So the floor is yours, doctor.
Oh, thank you, Dr. Carlo. I'm quite humbled and honored by those words. Thanks for your kind words. And so today I'm here to be talking to all of you on this topic that you see here, look beyond 2020, commonly missed or misdiagnosed conditions in pediatric eye care. So as I just told at the very beginning of this webinar, I'm quite excited and happy to be present for this unique venture of Doctor to Doctor World's Top 100 Podinar series, this global summit. And of course, it's like it's 20 minutes past 9 in India, so people must be sleepy, but I think they will watch this tomorrow. So what we are going to be looking at in today's presentation is just 3 simple cases and some of the clinical pearls that are relevant to these cases, and what is that we are referring to as missed or misdiagnosed, and some of the available evidence to support the diagnosis and management. So first, this is the first case for the day. This is the case of an 8-year-old male child. So his problem was this famous Simpson, the notorious Simpson, who's like having this difficulty looking at this moving text on the board. This child came to us with complaints of difficulty reading, copying down from the blackboard, and in general, the primary concern of the parent was with respect to academic demands. Some of the specific concerns where the child was using fingers to read rather than sort of being able to scan across the text. And the child also had difficulty seeing any objects that would move. And the child reported having some sort of an eye strain whenever the child wanted to read or perform any vision-related activities. And generally, the child was being reported as like clumsy by people who observed the child, like he would kick over objects that are lying on the floor, and he had difficulty even navigating in familiar environments and things like that. So the mother was quite worried because this child was actually examined, locally, had an eye examination, and then the child was told to have normal vision, and so nothing related to the visual acuity. Like as you see here, we all say 20/20 or 6/6 is what is the normal expected vision for all of us. And so when the child had this normal vision, people told that, oh, his eye examination is normal. So generally, he has good visual capabilities, and why would he really trip over objects on the floor, and why should he have difficulty with academic activities? And so as you keep thinking about, there is no significant refractive error, there is eye health is normal. So what else could be going wrong with this child that is potentially causing all of these visual difficulties? So we have to now dive a little bit deeper. So, for any child, any pediatric age group patient, we would take a detailed birth history, and that's what we did. When we dig deep into the birth history, we realized that he was the first and the only child born to these parents. He was preterm, 28 weeks of gestation. And what is more concerning was that he had neonatal respiratory distress. He was in the NICU for management of the hypoxia for almost a week. His birth weight was okay, and rest of the birth history was insignificant. But what actually happened later was like around 1 year of age, he developed epilepsy-like jerky movements, okay? And he also had breathing difficulty. So the parents took the child to a pediatric neurologist, an MRI was done. The MRI showed a subdural hygroma in the left middle cranial fossa. The child also had a small sized anterior temporal lobe. So the child's developmental milestones were reported to be delayed at 1 year. The mother felt that at 1 year he was not catching up with these milestones. And so now moving over to what as an optometrist or an ophthalmologist we should be looking at when you know that you have this sort of alarming birth history in place, and then you still have a visual acuity that is 20/20 or 6/6, what else you should be looking at? So basically, vision is not just, 20/20. Vision has different components. Some of the important aspects of vision are beyond the ability to see. It's about the eye alignment, like how well the eyes are aligned, because we see everything with both eyes open. We don't see individually with each of the eyes. So we had to do what we call as a cover test, where we looked at the eye alignment, and what we found that was the child had a large exo at near, which means the child was not adequately converging, and the near points of convergence were also receded. So when you take a target that is closer, a child should be able to see the target single, even when you take it closer to 6 centimeters or further. But this child was reporting that the target was looking double, even from 10 centimeter onwards. And the child's near points of accommodation, the ability of the child to be able to stimulate the ocular accommodation was good. But this receded convergence, like the ability of the child to maintain appropriate convergence and this large exophoria at near, were concerns at this point of time. But this is not just enough. We have to move forward with other aspects, which is again the ability of the fusional version system. So we tested the divergence ability and the convergence ability, and we found that the near convergence ability of this child is poor. So near, as you know, as all of us know, that that appropriate convergence is really important for all of us to be able to read efficiently. So if you do not have appropriate convergence, then you will see that the words sometimes become double, or it could become blurred, or it could appear to move on the page, and things like that. So that's what this child was experiencing. But because this child also had difficulty in reading, we wanted to look at the eye movements and tracking and things like that. So we also used what we call as a readalizer, an infrared eye tracking based device that would measure the reading speed and would also help us understand the quality of reading. So as you see here, this child had about the reading speed was about 75 words per minute. So this is definitely lesser than what is expected for the age, and the equivalent was close to grade 2. And so then we went ahead and then looked at the ability of the eye to make saccades and pursuits. So saccades are these rapid refixation from one target to another, how quickly you are able to switch your fixation. So as you see in this image, the child would be asked to rapidly switch fixation from one target to another, and then the optometrist would assess the ability, the accuracy, the head movements and the body movements of the child to be able to complete 5 cross strips, like going back and forth. And same way, you rotate it smoothly across in clockwise and anti-clockwise movements twice, and look at the ability, accuracy, and head movements and body movements. So you expect a score of 4 or 5, but this child really had poor scores when it comes to the ability to make eye movements, be it the rapid refixations or the smooth following eye movements. So basically, the diagnosis at this point revolved around these 4 key aspects. The first, as we just saw, was poor convergence or convergence insufficiency. The second is the child had poor reading capability. So it could be an oculomotor dysfunction, as you saw that the child also had poor saccades and pursuits. And it could also be any learning related visual issues because of the contribution of these difficulties onto the child's learning and academic performance. The last aspect of it is what we call a cerebral visual impairment. I would like to focus on this particular aspect. Of course, the word impairment would mean different things to different people. Here, though this child had 20/20 visual acuity, what do we mean by impairment? What is really impaired? So this is Dr. Gordon Dutton's inventory, which he named it as Insight. So this inventory is applicable to anybody who has had a brain injury, any sort of traumatic or acquired brain injury. As you see here, this child had a neonatal hypoxia related, insult close to the time of birth. So it's important for us to understand what this potential hypoxia related distress and the associated brain structure changes could contribute to the overall visual perceptual attributes. So we wanted to look at things in detail. So for example, this inventory will ask, this is just a sort of questionnaire or a survey that would be administered to the parents, and the parent is asked to respond to different aspects. For example, questions like this would be asked: does your child have difficulty walking downstairs? Does your child have difficulty seeing things which are moving quickly? This is basically what we call as the 5-item screening questionnaire. So though the main inventory has 40 plus items, this 5-item screening is something that any practitioner, including a pediatrician, can use whenever you see that a child has got sort of neonatal risk factors and also has potential difficulties around vision and academic performance. And if the parent gives you a history that any of these 5 items has, the child has issues, like on a scale, like this is a Likert scale where you grade the difficulty from never to always. So if you see that this child has difficulty copying words or drawings, locating an item of clothing in a pile of clothes. So all this is to do with the visual clutter related issues. And what this gives you at the end is like very simple. If you run the full questionnaire, it's quite simple. Like suppose if a child has difficulty finding the beginning of a line, this inventory at the end, once you administer, it's going to also give potential strategies that can be immediately advised to the parent. So it doesn't require like a specialist per se to really provide some of the useful environmental modifications and recommendations. Any medical professional who has fair amount of knowledge about this and who wants to help the child and the parent can definitely look at tools like this, where we can administer, find out what are the visual difficulties, what are the first level sort of modifications that needs to be advised to the parents. So this is how the inventory based recommendations comes out immediately once you fill in the inventory online. So anyone who wants to explore this further can definitely go and just type Insight approaches for visual perceptual difficulties, and Dr. Gordon Dutton has provided this graciously free of access for practitioners to use. And if you are somebody who are a hardcore like practitioner in pediatric eye care who wants to understand these things in much detail, there are many questionnaires. This is one questionnaire by Orbitus that looks at visual attitude, visual field, visual attention, influence, familiar environment, the dorsal and ventral stream aspects. I'm going to be talking about this shortly. So this is like a 47-item, a detailed CVI questionnaire that you can administer to look at specific difficulties and then provide recommendations. So our research group looked at a modified screening questionnaire and then we identified these questions basically as something that could really pick up children who have cerebral visual impairment related visual characteristics. And as you see here, these are statistical numbers, but I wouldn't be confusing you with this. But for example, if a child has difficulty finding it hard to find their way around even well-known environments, like this child specifically had difficulty navigating in even familiar environments. And if a child has difficulty with this particular item, this child is 25 times at risk of having features related to cerebral visual impairment. So you could easily use these sorts of simple survey-based tools and then pick up issues. Now coming over to what is the cerebral visual dysfunction or cerebral visual impairment? children born preterm in general are at a high risk, and a study has shown that the prevalence of cerebral visual dysfunction in prematurely born children is in the range of 21 to 47%. And so anybody who knows about an eye examination, most often we know about this aspect of eye examination, which is you get to see a visual acuity chart, you read lines, letters that become smaller and smaller. And so what does it do? It checks the integrity of the visual system, from the front surface to what we call as the visual cortex. So this is only the anterior visual pathway. But there is something called post-chiasm, like a retrogeniculate pathway, where you have all these different other visual perceptual functions that are being modulated. And so the cortical and the cerebral aspect. So from the chiasm to the cortex, from the cortex further to the parietal and the temporal lobes, these pathways are really, really important to be able to decipher the visual information that somebody sees. It's not just important to see, but it's really important to make meaning out of what you see. So the Dutton's tree of vision really puts this very, very simple. For example, all we know as I know everybody in the medical school would have learned about this, that the eye receives the visual information, then the optic nerve takes it to the optic chiasm, and through the optic tract it takes to the optic cortex. And that's all, like lateral geniculate, optic radiations, and the occipital lobe. So all of us know this part of the visual pathway, but what is really important is what happens after this. So the information doesn't stop its processing at the level of V1. So from the occipital lobe, the information is still taken for further processing or parallel processing from the occipital lobe to the posterior parietal lobes for basically anything related to visual search, visual attention, and visual movements. And from the occipital lobe to the temporal lobes for basically conscious recognition, to be able to recognize space, to be able to recognize words, to be able to recognize numbers, moving objects, animals, and naming colors. So these two pathways, which is the occipito parietal pathway and the occipitotemporal pathway, which we call as the dorsal or the ventral pathway, is really, really important to understand that how complex the whole visual system is, and it doesn't stop at the level of just reading 20/20 or 6/6. And so for all the other multidisciplinary practitioners who are keen on this topic, you can definitely look at questionnaires as screening tools for children with cerebral visual impairment. So the umbrella term cerebral visual impairment describes all conditions in which visual difficulties originate in the brain rather than the anterior visual pathway. So the most recent definition states this as a verifiable visual dysfunction which cannot be attributed to disorders of the anterior visual pathways or any potentially co-occurring ocular impairment. So all we want to emphasize at this point is that there is something beyond the visual pathway where vision really gets, it's complex processing, and we get to see the meaning of what we see. And so for this child, what we decided to do is, as the child had poor convergence, we started the child on vision therapy to improve the child's convergence. And we also looked at programs, visual perceptual vision therapy programs, to improve the child's visual perceptual difficulties. We referred the child for a detailed psychoeducational assessment, very, very important for the child to be seen by a pediatric psychologist or an educational psychologist. And we also referred the child to consult with a special educator and occupational therapist to work on some of the fine motor skill related difficulties. And based on the inventory, you get just a direct recommendation chart that you can hand it over to the patient for the parent for environmental modifications. And so basically, this is a child who typically has what we call as a high functioning CVI that has apparently normal visual acuity and normal eye health, and multidisciplinary management is something that's really, really important. This is the child's performance with one of the visual perceptual therapy programs that we have been giving to this child, and the child is really showing good progress. This is the first case that talks about the importance of a preterm and related risk factors around birth, implicating not just vision, but the visual processing and visual perception. This is a case, like a second case. This is interestingly a son of a pediatric ophthalmologist. So this child had poor convergence, and many of us in the eye care field would know that when you have poor convergence, we start treating the child for convergence insufficiency. Again, this child did not have any visual difficulties, so nobody thought in terms of, okay, this child does the child need glasses or any other management aspects. But when you look at the accommodation of this child, it is like really receded really farther. So what is important at this point is to pay more attention to the accommodation ability, not just only the convergence. So when you calculate what is the amplitude of accommodation for this child, it's just 5 diopters, but what is really expected for the age is like 13 diopters. So this child lags by about 8 diopters, like what's expected. From what's expected. So this child basically has accommodative insufficiency. So what further information is required? We have to look at in detail, assess the accommodation ability of this child. So when we looked at the near accommodation response, as you see here in this little video, the ability of this child to look at, to accommodate accurately to a near target that is held at 40 centimeters. This child had larger lags. This child also had difficulty in stimulating accommodation in general. So we went ahead. So this is an important test that, I would recommend to all eye care professionals, that all of us know about tests that we do for distance, like looking at distance vision and things like that. And we also know about the retinoscope that we use to look at what is the refractive error at distance. But doing a near retinoscopy, doing a retinoscopy at closer distance will give us a lot of information about the accommodation ability of a child. And so this is like, how to interpret the responses of this simple test. So the tentative diagnosis at this point, insignificant medical history. Still, we have not ruled out significant refractive error, because many times when we see 20/20, we don't think about, still, is there any sort of an uncorrected hyperopia or things like that. So these are some of the differential diagnosis at this point, which is uncorrected hyperopia, ill-sustained accommodation, accommodative insufficiency, or convergence insufficiency. So we went ahead, did a cycloplegic refraction, cycloplegic medications instilled, and then we found that this child did have about plus 1.5 diopters of hyperopic refractive error. Normally, in younger children, hyperopia is considered normal and even correction may not be required. But whenever you see that the accommodation is falling apart, or child has asthenopic symptoms, it's really important to correct for that little bit of hyperopia and look at what impact does it have on the child's other abilities, like accommodation, ability to read and perform near visual activities without much of an effort. So don't just, base your decision on just reading the distance chart, which doesn't do, doesn't provide you with all the visual capabilities of the child. So we prescribed a little bit of hyperopic correction for this child using a procedure called the Borish delayed, where you push the maximum amount of plus. With that, we found that the near points of accommodation as well as the convergence improved. And so what we did is we prescribed the plus, and we also started this child on vision therapy. So basically, the decision making for children like this, where we are in a dilemma, do we really need to correct hyperopia in a younger child? As I said, it's important to look beyond vision and to look at restoring the accommodation amplitudes to normal ranges, and whatever amount of hyperopia that gives single and comfortable binocular vision at near, that alleviates the symptoms of this child, is really important. So we prescribed this, and for further reading about accommodative insufficiency related treatment options, you could refer to a paper that we recently published. So basically, a conceptual framework in such cases should involve getting the symptoms right, looking at the refraction and paying a little bit closer attention to, just beyond vision, doing some of the basic binocular vision assessments, because vision is not just monocular. You need to look at the coordination of the eyes, and then do some specialized testing, but simple testing that could help you to take decisions and use cycloplegic refraction again to base your glass prescription. And make sure that accommodation amplitudes are normal before diagnosing convergence issues. This child is really doing very well. At about like 2 years follow-up, we discontinued the glasses and the child is doing like really, really well. This is the last case for the day, a very important case for the current context of COVID. This is a child who came to us like he was 12 years old. And so this is like a child from very, very interior rural place in India. So the father has been taking this child to doctor after doctor. So when he took to a doctor, the doctor prescribed like minus 4.5 because it improved the vision to 6.6, because this child like said, I cannot see. So that the person put some glasses, the child could see 6.6, and then the glasses were prescribed. But the child did not, feel all right. He kept on complaining about having headaches and eye pain, and he was looking quite anxious and stressed. And when he came to us, even with this without this prescription, his visual acuity was like really 6/60. He could just read the first line of the chart. And when we did a retinoscopy, what we found that it was highly varying, which means his accommodation is not really sort of relaxed or stable, accommodating too much, like he's sort of getting into the spasm of accommodation stage. And we did a cycloplegic refraction. So in such cases where there is a high amount of variability in refraction, and you see something like this, like all of a sudden the very first glass prescription itself is like minus 4.5, you should really think about, oh, are we overcorrecting? Are we like missing something? You should not just prescribe glass that just enables the child to read 6.6. You should really look at what's going on behind the scene. So after the strongest cycloplegic atropine eye ointment was instilled, this child had plus 0.75, and the child also had a sort of esotropia where this child was showing tendency to converge excessively as well. The rest of the eye examination was normal, and all this electroretinogram, the visual fields, the visually evoked potentials, this MRI, all this has been performed, was advised locally. The father has done all the tests, and all these reports were brought in by the father. But all that the child required was a proper cycloplegic. And so we prescribed, a long-term cycloplegic in this child. We co-managed this child with our pediatric ophthalmologist. So this child was prescribed homotropin 2%. This child had very severe accommodative spasm. So we went ahead to another stronger cycloplegic, and it did resolve the condition. And at 3 months, this child had, without any glasses, normal visual acuity. We also continued vision therapy and visual hygiene. But as something I need to point out is this anxiety and stress. This child had lots of family-related conflicts, parental conflicts, another younger sibling who sort of spastic cerebral palsy. So there was so much going on in the family, which really affected this child. And so it's really important to look at what triggers the spasm. So this is a publication that we've got where we speak about some of these aspects, and also provide a management approach. So what is important is to look at psychogenic etiologies and refer the child to a pediatrician, a pediatric counselor, or a psychologist for appropriate psychotherapy and management aspects, because it's not just important to just look at the vision and manage that aspect alone. And when there's a recurrence of the spasm, it's important that the cycloplegia is continued for longer time, and vision therapy again to make sure that this accommodative spasm, this pattern of excessive accommodation is sort of like broken at some point. And again, near addition glasses, because you put this child on cycloplegics, especially in hot and humid countries like India, we can't go out. The sun is going to be up and bright, shining all through the day. So it's important to prescribe the child with photochromic glasses, so the child does not have photophobia and related headaches and things like that. So it's really important to look at a holistic management. And this is a very recent paper that just came last week that talks about the impact of COVID-19 home confinement in children's refractive errors. So across the globe, there are so many other publications in pipeline, and sure. So this paper that's based in Spain talks about how the lifestyles of Spanish children changed during the home confinement at the beginning of 2020. So compared to 2019, in 2020, there has been a sort of a shift towards myopia in children in this part of the world, not just in this part of the world, but across. And what is more important with respect to this particular case is that some of the sort of a shift that you see in these child's refractive error may not be just myopia and myopia related progression. It could be even just spasm of accommodation. So it's really important to make sure that we manage them with a holistic mindset. So the take home for this particular patient is that, again, don't give a prescription just to restore the vision to 2020. And it's not just important that an optometrist or an ophthalmologist manages the patient, but we need to make appropriate cross referrals to look at a holistic management so that the child not just have an immediate resolution, but long-term sustainability of the results that we achieve. And so you could look at simple strategies apart from just doing your normal refraction, like doing your near retinoscopy, doing your Borish delay testing, and look at sequentially managing the patient, like providing appropriate glasses, near addition wherever required, and then vision therapy. So even if a patient says that I could read the smallest line that is written on the chart, it doesn't rule out these problems that we discussed in these three kids that, that could be related to beyond just the ability to see. So vision is beyond 2020, and any feedback or queries can be directed to this email. And this is the beautiful team that I am blessed to be working with. This is a team of Binocular Vision in Shankar Netralaya, and this is the team of Special Children Vision Clinic. So where we all, we have a beautiful optometry ophthalmology setup where we get to work and see patients in here. So that's my presentation, Dr. Carlo, and I would like to direct back to you for any.
Thank you so much, Dr. Jameel, for the actually very informative lecture. So, well, as a dentist, most of the terminology is actually, of course, unknown to me. But well, I'd like to encourage everyone. If you have any questions, you can write it down. You can type it down. So I think Dr. Jameel will be answering them after this program of ours. Okay. So I have a question, Dr. Jameel, if you don't mind. I'd like to ask about eye-related headaches. So, what's the mechanism of this, right? Because it's really and in relation to the pediatric part. So, adults have eye-related headaches, and glasses fixes that. Correction of the vision fixes that. So, I'm sure if a child has a vision problem, the child also experiences this. So how, as a parent, how would I know that my child experiences this? I'm sorry if it's a layman's question, but I hope you could answer it, doctor. So.
No, you're asking a very, very sensible and a relevant question. That's important for all medical professionals to be aware of, because many times headache is just like that complex terminology which could be caused by 100 odd reasons, right? So how do you really know that it's being triggered by eye and vision related issues? So one thing, as you said, is the common thing is, of course, the need for a glass, the need for a simple glass. If the child is not able to see well, and if the visual disturbance is present, either for near or for distance, because when the child wants to look at the blackboard, or for now when they want to look at these gadgets and things like that, or want to watch TV, whenever there is a vision, the strain on the visual system, like the ability to see clearly, when that gets affected, the child has to strain to see, like the child either squeezes the eye. So that causes, the muscles on the frontal and the forehead portion to sort of work a little bit more. And also the intrinsic muscles of the eye and the crystalline lens that gets to sort of work a little bit more than what's required. So all this sort of extrinsic and intrinsic, processes, leads to headaches. But there are other causes beyond glasses, as I just discussed, beyond glasses. Now that when you take something close, you start seeing double, right? So whenever
Yes,
you
yes.
try to do this little bit, you just take it closer, right? So this is what is the ability of both eyes to sort of, maintain convergence on anything that you see and
Mhm.
see things clearly. But when a child does not have good alignment, instead of the eye being straight like this, if the child's alignment is like this, a little bit diverged, which is
Mhm.
not, which wouldn't be seen so obviously, because when
Okay.
you see it so obviously, then you call it a squint or strabismus. Then you refer the child, because you see it manifest. But now this is all hidden, but the child's position, the eye position is little bit drifted outwards. We call it exo. In those cases, the child has to put extra effort to bring the eyes inside
Okay.
and then work. Now that's going to lead to problems like words will appear to move on the page or will appear to look blurred. The
Mhm.
child will generally say, I just don't want to read. Many times parents will think the child doesn't want to read, and they take the patient to a doctor. The doctor examines and then says, oh, the child has normal vision, no glasses required. But when you test for this convergence, the simple test, you know that child has poor convergence. And all you need to do is to train the child for this particular ability, and boom, child does well. So these are some of the commonest visual issues, concerns in children that could lead to headaches.
Okay, thank you, doctor. So, I have a follow-up question because I, as a kid, wore glasses, doctor. So, my parents would often tell me that it's because of playing video games. And my kid, my daughter, like this pandemic, they're really well versed in tablets, in the iPhone. So, is this true? I mean, does it strain the eyes if video games and a lot of screen time? So for most especially for children, doctor.
Yeah. Again, a very, very relevant question for the current times. And though the lockdown is lifted in many parts of the world,
Mhm.
like, of course, still kids are on to virtual online classes. This is like a very, very relevant question for the current timings. So not just like any sort of a near work, okay, continuous task at closer distance. Especially children tend to take things a little bit closer than
Yes,
usual.
yes,
So
yes.
whenever we do this, this accommodation, like as I just discussed, it tends to really work a little bit more than what is expected of the system.
Mhm.
So constantly when the child does it without really relaxing or looking at a far off object, then that definitely in the long term can lead to even the need to wear glasses for myopia. Or if the child already has been using glasses, then it could also result in increase in the power of the glasses. But there are very simple things that we can do. One is looking at the lighting. Many children tend to sort of like, at bedtime with lights off, lying
Oh
down
yeah,
and then playing,
blanket
right?
under the blanket. Yeah. So
Under the
yes,
blanket.
under the blanket.
So yeah, so making sure that the lighting is good, and then you don't indulge in like, sort of under dark environment, like where the system has to work more.
Yes.
Second thing is
Okay.
natural light. There's so much research that's going on in here, like does gadgets really lead to problems? But what is really coming out very strongly is that a minimum of 2 hours of outdoor activity, any sort of an outdoor activity, be it play or just sort of like spending time outside in the garden or whatever, any sort of an outdoor, 2 hours of outdoor is the only protective factor against this myopia onset.
Oh.
Okay.
Okay.
So the whole the medical community is advocating for this. Is like a multidisciplinary thing. Like you could, as
Yes.
a
Yes.
dentist, tell your kids to go and do it. The pediatricians can tell the kids to go and play
Mm.
outside. The orthopedicians, because it results in increased improved bone density and
Yes.
vitamin D
Yes.
exposure and stuff like that production. So this minimum 2 hours of outdoor exposure has been shown to be beneficial with respect to lots of aspects of vision, especially in terms of the need, to wear eyeglasses. So working in natural environment, taking frequent breaks, like you can
Mm.
put in your alarm saying like not more than 20 minutes. We call this 20 20 20. Every 20 minutes once, take a 20 seconds break. So what do? Look at 20 feet, like far off at 20 feet for 20 seconds. So after every 20 minutes, just all of us, in fact, any one of us who are glued onto our gadgets and computers can just take a break after 20 minutes for just 20 seconds, look around, blink and things like that and get back. And the same thing can be even, uh, advised for children, especially they can take a little bit longer, maybe like 5 minutes break or things like that. So basically, you have to break this continuous cycle, because the longer they work, the longer they do these tasks, the more they are at risk. And the lighting is very, very important. And so you need to sort of provide them with natural lighting. And the younger they are, the more cautious you need to be, because that is the age where the eyeball is undergoing rapid growth. So the age of the 6 to 11, 6 to 12 is when, this whole process of visual development is taking place. This is the age where you need to be cautious. And if parents have myopia, one parent, two parents, one parent, 25% risk, two parents, 50% risk. So if parents are also myopic, if they have a family history, then be more cautious. Let the child go play outdoors for at least 2 hours.
So this is genetic, right? So I mean, what you're saying is, if it's really, genetic, it doesn't, having poor eyesight, it's not because of it. It progresses. It's genetic plays a big factor, doctor, right? So
Yes,
all
it
right.
does.
So
But
wow.
what recent researchers are telling is that it's more of epigenetic involvement is there. So beyond genetics, there are environmental factors,
Mhm.
both within the body as well as outside the body, that guides the whole process. So it's really important for us to set right the environment, because we see children who does not have any family history, but having the need to wear glasses now. And so what does that tell us is that the environment plays a much, much more crucial role in driving these processes. So it's really important to understand the role of environment and look at how we can sort of mitigate these outside factors that we do have a control of. Of course, genetics, we do not have a control, but looking at the other factors that we do have a control of, looking at those modifiable risk factors, definitely will help us taking this whole myopia, epidemic to pandemic, uh, control to a greater extent.
Okay, thank you, doctor. So, I think I'm entitled for three questions. My last question, doctor, is how early does a child? I mean, if given that a child has some visual problems, how early does a child wear eyeglasses? I mean, as early as like 2 years old. I mean, what's the like the
Right.
the youngest age? Yes, yes, doctors. Mhm.
Yeah, that's a great question. Actually, it completely depends upon the visual problem that we are dealing with. Like, for example, if you take the worst situation, like a child who's born with congenital cataract that needs to be operated as soon as possible, like, even at 1 month of age or whatever, as soon as this
Oh, wow.
cataract is detected, then this child needs to wear really thick or fakey glasses immediately after the surgery for visual rehabilitation. So any sort of ocular pathology
Okay.
related management starts, as soon as the condition is detected. When it comes to refraction, just the need to wear regular eyeglasses,
Mhm.
again, it depends upon, like, for every age we have specific cutoffs for like what is expected
Mhm.
for the age. So whenever the child gets its eye examination done, and when you know that their cutoffs are falling apart, then that's the time when they need to be wearing glasses. Again, there is no minimum age or like an age at which
Okay.
they need to be wearing. Anytime you just pick up the problem, and you, because uh, this whole uh, the period of visual development is very critical in a child. Like, if you don't provide appropriate refractive correction glasses, the child can develop what we call as amblyopia, because the brain is not receiving appropriate visual information. So the eye tends to become lazy. And even say after 8 years of age, if you give glasses, vision may not be restored to its normal levels. So it's really important to correct uh, the refraction at the earliest age at which it is detected, so that visual acuity is restored to normal levels and the child does not end up with having amblyopia.
Okay. So, doctor, is there a situation that because if you have, for example, yeah, like astigmatism, it's usually progressive, right? So is there any situation that you can cure it? You can right, stop. It's cured. So or it's really progressive. Is it really
Yeah.
progressive?
Yeah. So
The
myopia is really progressive than
Okay.
astigmatism.
Okay.
Astigmatism tends to be more or less stable. So now coming to the permanent cure, unfortunately, there is no permanent cure for children. For adults, yes, you have
Oh, okay.
laser refractive surgeries,
Yes,
all
yes.
modern laser corrections that are available for people beyond 18 years of age. When
Yes,
the
yes.
refraction becomes stable, there is no progression. They can get their glasses removed through all the modern advance in refractive correction, refractive surgery related procedures. But when it comes
Mm-hmm.
to children, because they are in this malleable stage where things tend to keep changing, progressing, and so it's so nothing is advised at this point other than glasses. Maybe after a certain age, like 13 or 14, they can go in for contact lenses. When it comes to
Yes.
myopia, there are lots of treatments that are currently being practiced to control the progression, because it's really important to control the way this change is happening, because every
Mm-hmm.
diopter of progression increases the risk of other ocular complications inside the eye,
Okay.
because when the myopia becomes more and more, that can lead to retinal complications and sight threatening complications. So it's really
Mm-hmm.
important to control the progression. That's where we say public health strategies like outdoor. The reason why we keep saying outdoor, outdoor, outdoor is that it's such a freely
Yes, yes.
accessible thing for everybody that's got a huge impact on this
Mm-hmm.
progression and this whole myopia story. So it's really important that we do it. And if you have a child that's increasing rapidly, like every year the child is progressing, say, by more than half a diopter, more than like close to a diopter, it's really important to look at myopia control options. This could be
Okay.
pharmacological options like atropine, low dose atropine eye drops, or orthokeratology, contact lens based treatment options. There are other various optical treatment modalities to control the progression, multifocal lenses and things like that. So it's really important that we also look at control strategies for myopia progression.
Okay. Well, that ends actually my questions. Again, ladies and gentlemen, if you have questions, you can just type it below in the comments. Dr. Jameel will happily answer those questions later after the show. So I've learned a lot actually. Thank you, Doctor. I mean, it's quite. I'm really gonna practice that outdoor thing that you're saying, the 2020 tomorrow, no, tomorrow it's actually night, it's night here, but tomorrow I'm going to do that, so to balance my child's time with her tablet and of course the outdoor. So thank you, Doctor. Again, congratulations in being nominated and being part of the top 100 and our doctor to doctor events that we actually uh, encourage everyone to, every healthcare professional to be part of this. It's quite exciting. Like it's the first time that I've interviewed and talked to an optometrist, and it really, makes me excited, and I get to know a lot of information about our eyes. So again, Dr. Jamil, thank you so much. So I'm very, very blessed that I got to know you and got to hear your lecture. And to all that our viewers, thank you so much for listening. So again, this is Dr. Carlos Santos from the Philippines. Okay, and Dr. Jamil, would you like to any bye bye words for our viewers? Any messages, Doc? So
Oh, thank you, Dr. Carlo, because it's
yeah.
not easy for this cross disciplinary management that you have done. Like, you've been so kind and patient to sit with this lecture of mine. I just highly, I'm just thinking if I would sit with the dental lecture, but maybe if you do, definitely I would be sitting over and listening to your lecture. So thanks so
Thank
much
you, thank
for
you.
your kindness, to for hosting this event, and
Of
also for
course, of
moderating the
course.
session.
Yeah.
And your questions were all so valuable, so relevant for the current situation and context. So
Thank you so
thank you once
much.
again. And thanks to the entire
Okay, so
top 100 doctors forum for this opportunity. And I'm so happy to be, be present with all of you. Thank you once again.
okay, thank you again, and to everyone, have a blessed day. Stay safe, everyone, and please share the videos. Share it to your friends, to your relatives, to everyone. So, again, good day to everyone. Take care, everyone. Okay, bye bye. Bye, Doc.
Take care. Bye, Dr.
Bye bye.
Carlo. Bye.
All right.
Bye.